We are starting with the trauma series 9, thermal injuries, first about the burns. Talking about the burns, we are classifying burns according to the depth of involvement of the skin. So normal, then first degree burns which will only affect the epidermis level, and second degree burns which will move up to the papillary dermis, and the third degree burns which will go into the deep into the dermis, deep dermis is involved, and the fourth degree burn which will go deep into the muscle and bone. We'll see each type of burns in detail. So first degree burns, the epidermis only is involved and dermis and subcutaneous tissue are normal. No need of fluid resuscitation in such cases as the epidermis is intact. There is no fluid loss occurs in here in first degree burns. Second degree burns now. So regarding second degree burns, it is when it is superficial, it is affecting only the papillary dermis part of the skin. So it is up to the papillary dermis deep and homogeneously pink and blanches to touch. So blistering can happen, which is painful, and the skin will be very glistening and the wound bed will be glistening. Again, second degree deep burns, it will be mottled with non-homogeneous red and whitish and does not blanch to touch, and it is dry and insensitive to light touch or pinprick, and it will involve deep dermis level. Now it's time to discuss about the third degree burns, which is deep burns or full thickness burns, and it is homogeneously whitish looking all through. The full thickness burns usually appear leathery, the skin may appear translucent or waxy white, and surface is painless to light touch or pinprick and generally dry. Once the epidermis is removed, the underlying dermis may be red initially, but it does not blanch with pressure. It's time to think about the rule of nines, how to calculate the percentage of affected area. We can have the head as 9 percentage, front of the torso is front of the chest is 9, front of the abdomen is 9, 9 plus 9, and back also it is 9 plus 9, 18, and upper limb it is 9 for 1, so other upper limb is another 9, lower limbs in the front of the lower limb is 9 and back of the lower limb is 9, so 9 plus 9, and other limb is 9 plus 9, and 1 percentage for genitals. That's about the rule of 9, Wallace rule of 9, and rule of 9s in kids. Infants we can calculate by head as 9 percentage. The upper limbs front and back is 4.5 percentage each, and body the back by 13 percentage, and front of the torso is by 18 percentage, buttocks 2.5 percentage each, and 7 percentage for the lower limbs, front and back. Sometimes in kid it will be somewhat difficult to measure, so we can use a London Broadest chart for calculating according to the age. We should be really careful while calculating the percentage of burns in infants and children because over resuscitation will very soon lead to fluid overload in such patients. Next is the rule of palm. Rule of palm has different school of thoughts. One is saying that 1 percentage for the palm excluding the fingers. Another school of thought is like that when it is in children, we can consider the palm without the fingers as 0.5 percentage. Including the fingers, then we can take it as 1 percentage in children. Always remember in rule of palm, we are using the palm of the patient, not the examiner's. Now that we looked at the classification of the burns according to the depth as well as how to calculate the percentage of burns, we will now move on to the burns management principles. General management is like that: stop the burning process is the first step and establish an airway control, and you give adequate ventilation for the patient, and finally we have to do the burn shock management. Burns will have severe hypovolemia due to the loss of fluid from the body because of the loss of skin. Finally comes the specific assessment and management of burns according to the type. Although many factors may influence the prognosis, the severity of burn, the presence of inhalation injury and associated injuries, the patient's age, comorbid conditions, acute organ system failure are more important factors. First step is first aid. So stop the burning process. How to stop the burning process? It is by removing the clothing. The clothing has a problem. If you have linen or silk kind of cloth, it will be stuck into the body after getting burnt. Secondly, preventing hypothermia. So as the skin is getting lost, so much of heat will be dissipated from the body, and preservation of the heat will not happen, and it will suddenly go into hypothermia. Moreover, we are giving large amount of fluids also in the burns, which will again cause hypothermia. And stop, drop, and roll is one method when we can use when our as clothes are getting in fire. Let's look at the next priority, establishing airway control. The causes of airway compromise can be inhalational injury, can be airway edema. In children, there is smaller airways. There will be more edema and more chance of obstruction. The airway predictors are oropharyngeal redness, soot in the pharynx, edema will give us a clue that the airway is compromised. Indication for early intubations are the signs of airway obstruction, extended burns more than 45 to 50 percentage, deep facial burns, airway edema or risk of edema, difficulty in swallowing, and respiratory compromise, inability to clear secretions, respiratory fatigue, poor oxygenation or ventilation, and requiring transfer to the other center. Before the airway is getting edematous and compromised, we can achieve an early definitive airway and shift the patient. Surgical airway, due to the edema, it is really difficult in case of burns patients. So, unless you are expert in surgical airway, it is a last resort. We have to prepare for supraglottic airway devices and other adjunct methods while preparing for airway in such patients. Adequate ventilation. Direct thermal injury to the lower airway is very rare and essentially occurs only after exposure to superheated steam or ignition of inhaled flammable object. Breathing concerns arise from three general conditions such as hypoxia, carbon monoxide poisoning, and smoke inhalational injury. In circumferential chest burns, there will be poor compliance of the chest and it will cause more hypoxia and increased pressures during ventilation. And carbon monoxide poisoning is another problem. With the levels of carbon monoxide poisoning will be directly proportional to the symptoms the patient is having. Less than 20 percentage will have no physical symptoms. At the same time, more than 60 percentage can be even fatal. The thing about carbon monoxide poisoning, in closed spaces it is more. And 100% oxygen supplementation can be the treatment we can give for carbon monoxide poisoning. The pulse oximeter is not reliable in case of carbon monoxide poisoning, and no role of hyperbaric oxygen is identified. The smoke inhalation injury occurs more in enclosed spaces, and the smoke particles in the distal airway will cause mucosal damage, and the necrotic cells will slough off and will obstruct the distal airway. That is a mechanism of distal airway in smoke inhalation injury. The smoke inhalation injury can be more in case of extremes of age. In less than 10-year-old or more than 50-year-old, even 10% of burns can cause inhalational injury. Now we are moving to the heart and soul of the glass, circulation and shock management. So in burns, there is increased capillary leak. That is the primary cause of fluid deficit in burns patients. So we have to give fluids. What fluids you want to give? We'll give ringer lactate is a preferred choice of fluid. And careful fluid resuscitation is required in all the patients with more than 20% surface area burns. There is no problem in placing an IV line through a burnt skin if a normal skin surface is not available. And BP monitoring in a burns patient is typically very difficult. If BP monitoring is difficult, we have to rely on the urine output for assessing the perfusion adequacy. Next, about the Parkland formula. The classical Parkland formula has been modified nowadays. So the new formula is 2 into body weight into percentage of surface area burns. So consider only second and third degree burns while calculating the Parkland formula. One half of the calculated fluid volume to be given in first 8 hours and rest to be given in the next 16 hours. For example, if a 100 kg patient with 80% of burns comes, then 2 into 100 into 80, that means 16,000 ml of RL in 24 hours. So we'll divide it into 2, 8,000 ml in first 8 hours, that means 1000 ml per hour, and 8000 ml in the next 16 hours, that means 500 ml per hour. So after 24 hours, we have to target the urine output and we have to adjust the fluid volume. And the 2 times body surface area is not always true. In case of flame and scald injuries, in adults more than 14 years, there is 2 into body weight into percentage of TBSA. And the urine output target is 0.5 ml per kg per hour. In children less than 14 years, it is 3 into body weight into percentage of total body surface area, and the urine output target is 1 ml per kg per hour. And infants and young children of less than 30 kg, we have to give the fluids in 3 into weight into body surface area, and the solution we have to add a dextrose also, means 5D is added to the solution, and the urine output target will be 1 ml per kg per hour. In electrical injuries, all the electrical injuries are considered as deep to the bones and muscles, even though it may look a entry wound with a small area of involvement. So, in electrical burns, it is considered as 4 into weight into percentage of body surface area, and the urine output target will be 1 to 1.5 ml per kg per hour. Now, that the important aspects of the ample history we have to ask in burns patient. First, about the essential things in the emergency history of burns is whether it has happened in a closed space or an open space. If it is a closed space, there is more chance of inhalational injury possible, and carbon monoxide poisoning can be more. And time of the burns, to assess how much fluids has to be given over how much time, we have to know the exact time of burns, and the brief survey of pre-existing drug therapy and pre-existing illnesses also, to decide whether to give aggressively fluid or to restrict it. And previous drug allergies should be asked, and check whether the mechanism of injury matches with the pattern of the injury. If the mechanism is not matching with the pattern, it can be an abuse victim. We'll move on to the secondary survey of burns patient. So first, about the documentation. The documenting the time of arrival, the management you have done, the flow sheet is very important to maintain, and should be sent to the burns unit when the patient is getting shifted to the burns unit. And baseline investigations, including the CBC, cross match, ABG, carbon monoxide, and serum glucose, electrolytes, pregnancy test if patient is in reproductive age group, and post-procedural chest X-rays if any procedure has been done. So look for circumferential extremity burns. So it can cause compartmental syndrome, as the compartments will get compressed in between the facial structures. Talking about the compartment syndrome, it is one of the dreaded complications of burns. So it can occur because of the circumferential burns, which occurs in the extremities. Pressure of compartment of more than 30 millimeters of mercury considered as compartment syndrome. And compartment pressure should be more than systolic BP to hamper the circulation to the limb. There are 5 P's of compartment syndrome. So initially there will be pain on passive extension, and pallor, pulselessness, paresthesia, and finally there will be paralysis. If the paresthesia and paralysis occurs, it is irreversible stage of compartment syndrome. There is a striker device which you can see in the figure, which is used for measuring the compartment pressure. Regarding treatment of compartment syndrome, we have to remove all the jewelry which is in the limbs, because once edema sets in, we cannot remove the jewelry and it will cause additional pressure onto the limbs. And frequent assessment of the peripheral circulation with the Doppler ultrasound is important to assess the pulsations which is absent or present, we can see. And if it is a circumferential bone, then we have to do and go in for a escharotomy. Escharotomy is done in specific lines in the body, which is depicted in the picture. The picture you're seeing is post-escharotomy done in a patient with circumferential burns. Fasciotomy at the same time is different from the escharotomy, that it goes deep and opens the fascia to, to expose the muscles, so that the muscles will get some space and the pressure is relieved and have some amount of blood flow to the vital organs inside the fascia. Management principles and considerations of chemical burns. Chemical burns can be caused by the corrosive agents such as acid, alkali, or petroleum products. So, alkali is more dangerous and it penetrates through the lumen. An outcome of chemical injury depends on the duration of contact, the concentration of the chemical which is exposed to, and amount of agent exposed to. Regarding the treatment of chemical bonds, flushing away the chemical which is causing the erosion is the first and foremost thing. So, at least for 30 minutes, we have to flush away the chemical with saline. Do not use a neutralizing agent, because neutralizing reactions are exothermic reactions which will cause more erosion to the organ. If you see, you can see an erosion in the eye. Which we can irrigate the eye for 8 hours continuous with a cannula fixed in the palpebra for irrigation. More about the management of chemical injuries to the eye has been discussed in our ocular trauma video already. Before the next section, don't forget to like, comment, share, subscribe the channel for more videos. Next, we will discuss about the electrical bonds. Regarding electrical burns, particularly the skin surface may look normal, but deep down the burns will happen. This is because of the high energy which is dissipated into the deep tissues than it is corroding or eroding the surface of the skin. Burns is more severe than they appear. A clenched hand with a small electrical entrance wound should alert the clinician that the deep soft tissue injury is likely more extensive than it is visible in the naked eye. Cardiac monitoring is very important in case of electrical burns because high chance of cardiac arrhythmias with electrical burns occurs. So monitor the patient with a high voltage injury, loss of consciousness or burns occurring due to electricity. Because electricity causes forced contraction of the muscles, the clinicians need to examine the patient for associated skeletal and muscular damage, including the possibility of fracture of the spine. Rhabdomyolysis from electricity traveling through the muscles result in myoglobin release, which can cause acute renal failure. Electrical burns are typically low voltage and high voltage electrical burns are there. The high voltage electrical burns are more severe to cause rhabdomyolysis. Regarding rhabdomyolysis, it occurs when burns occurs deep to the muscle and bones. So electricity travels to the muscles, the myoglobin will release in the urine, which will cause myoglobinuria and rhabdomyolysis. And do not wait for the lab confirmation to start the treatment. So diagnose it clinically with the color of the urine, which is going to be dark cola colored, and treat aggressively to maintain the output targets. Urine output target will be more than 2 ml per kg per hour initially, and once the urine is clear, to maintain more than 0.5 ml per kg per hour. So you can see the filigree burns, which is occurring due to electrical burns as well as high voltage lightning burns. Entry wound may look at very small, but extensively would have burnt inside the tissues. Next, we'll discuss about some special situations in burns. One is the tar burns. The temperature of the molten tar will come up to 232 degrees Celsius, which will cause burns in the skin, as well as the problem is high adherence to the skin becomes a challenge to treatment. The treatment of the tar burns includes rapid cooling of the tar and take care to avoid the further trauma while removing the tar. A number of methods are reported in the literature. The simplest one to use a mineral oil to dissolve the tar. The tar will dissolve with the oil, and the oil is inert and safe on injured skin and is available in large quantities. So next about abusive burns. Abuse burns is more common in kids and old age. Circular burns, the burns with clear edges, raises a suspicion of abuse burns. Burns on the sole of the kid, which will typically occur when this kid is dipped into a hot water, and burns in the buttocks and back of the lower limbs of elderly will also raise a suspicion of abusive burns. And old burns, say in the setting of a new traumatic injury, that means different kinds of trauma is happening in different times, then it will raise a suspicion. Most of all, history and injuries are not matching, then suspect an abuse. Documentation of the same and reporting it as a medical legal case and informing the child protective authority will be the actions to be taken in abusive burns, apart from the regular evaluation and treatment of the patient. Moving to the final session, when to transfer a burns patient to a burn center. Partial thickness burns on greater than 10% total body surface area. Burns involving the face, hands, feet, genitalia, perineum, and major joints. Third-degree burns in any age group. Electrical burns, including lightning injury. Chemical burns, inhalational injury, pre-existing medical conditions, burns with any associated other trauma in children, and patients requiring special assistance. Next in the series will be musculoskeletal trauma, the video number 8. Stay tuned.